Thanks everybody for joining today. I'm super excited to be talking to you today about the work that we're doing at the Shannon Parker Center. I'm Sharon Chinthrajah. I direct our clinical research unit. And I have a wonderful team, that really makes the magic happen at our center. Some of whom are on the line with me today. And the topic for today is anti-Ige in food allergy, and talking about some of the clinical trials that are currently going on at Stanford and across the country, and thinking about how this will become hopefully available to the broader community outside of research centers, hopefully in the near future. And so this is actually the artwork from one of our publications, one of our studies, the MAPX study that was published in Lancet, and I'll go through that today. And the artist did a beautiful rendition in my mind, because it captures so many of the important things that we think about when we think about our food allergy patient that we see in our clinics and in our center. Typically they're children. Typically food allergy patients have more than one allergic disease. Sometimes they have asthma. Sometimes they also have eczema. Sometimes they're allergic to pollens in the air, and in addition to the foods. And all of this is really driven in allergic diseases by the IgE antibody. So that's these little Ys that you're seeing here in this picture. This IgE antibody here, you're seeing it mounted to a cell, and sometimes it's free floating in your circulation. And that's what we're trying to change when we're talking about oral immunotherapy or anti-Ige drugs. And we're very lucky to be in this time and place to have one Ige medication, a biologic called Omalizumab, that kind of attaches to these Ige antibodies to take it out of circulation, and another Ligolizumab that's also being studied in food allergy. So oral immunotherapy, our current state. Many of you know that our center has done quite a number of oral immunotherapy studies, some of our own design and some that have led to pivotal indications, such as Palforzia being approved by the FDA. And that is peanut oral immunotherapy for children 4 to 17 years old. And then there's others in the community that are doing oral immunotherapy with peanut and other foods. The benefits are that you get full or partial desensitization in over 80% of folks who we try oral immunotherapy. And that's a lot about selecting the right patient for the right treatment option. So that's a really important conversation that allergists are having with their patients who have food allergy. And that some of you have also contributed to our long-term follow-up data, so that once you've finished oral immunotherapy, we send you questionnaires to understand how you're doing, because we know in clinical trials, when you're seeing us or when you're seeing your doctor on a regular basis, that we can be your cheerleaders on the side because you guys are doing the hard work at home. But what happens when you don't see us every 2 weeks in the research center? And 62% of patients continue to include oral immunotherapy in their diet 1 to 10 years after finishing a clinical trial with our center. So this is some of our long-term data. And I think we're one of very few sites across the country that has a patient population that's so engaged with us and research and continuing to contribute to the field. Some of the limitations of oral immunotherapy is that it can be a slow process, that you can have side effects or adverse events. And the most common are GI side effects, an itchy throat, stomach ache. And then some limitations are that it is specific for the food that you're taking for oral immunotherapy. And I think some of our studies have shown that there might be, there is cross desensitization. So if you have oral immunotherapy for walnut, you get some benefit for pecan. If you have oral immunotherapy for cashew, you get some benefit for pistachio, but less is known about but the other kind of benefits from the other food groups. And so really it's about, taking that particular food on a regular basis for oral immunotherapy. I like to show this slide because patients are always asking us, well, how long for your studies that you're doing in your center to reach the community, to be widely available for diverse patients, diverse populations all across the country. And I share this because we start here on the left side, going from basic research and drug discovery and preclinical work, which is often done in animals and not in humans, to make sure that potential drugs are not harmful. And this is the process of getting it approved through the FDA. And so we have phase 1 clinical trials, phase 2 clinical trials. Phase 1 is trying to see, okay, does it cause any side effects and is it safe in humans? Phase 2 might be trying to find the right dose and continued safety in humans and efficacy. Does it work? And phase 3 is doing it across a broader population, involves large numbers of people in the clinical studies, often across multiple different sites to get really good geographic representation of diverse communities, and then goes up for FDA review, and then hopefully gets approval like Palforzia. And then phase 4 is to continue to study that drug as people adopt it into their clinical practice and learn more about its use or side effects. And so this is a long pipeline, but what I'm sharing some excitement is kind of this pipeline for anti-Ige therapy from the Stanford perspective. So why think about anti-Ige? As I mentioned, food allergy is an IgE-mediated allergy, and we're lucky because there are other IgE-mediated allergies, like seasonal allergies, like sensitivity to stinging insects. And we've had some good drugs around to be able to, help with those diseases, like allergic asthma as well. And we've taken that drug, Omalizumab, and also studied it in food allergy. So Omalizumab is one of 2 IgEs that are currently being studied in food allergy. It's the most widely studied biologic therapy for food allergy, the anti-Ige biologics, because we're taking IgE out of circulation and taking it, reducing the function of it on basophils and mast cells, which are allergic cells that are in our body. And as I mentioned, Omalizumab or Xolair is the most widely studied agent for food allergy. It's been studied by itself and in combination with single or multi-allergen oral immunotherapy. And it's been shown to be safe and effective in doing aiding food allergic patients to become desensitized. And I'll show you some of that data. So one of our first studies, which is a phase 2 study and a pilot study here at Stanford, was our MAP-BEC study. Some of you from the community and here today might be families who participated in this study. We looked at 48 patients and it was a randomized controlled study. So it had a comparison arm where 36 of the 48 folks received Omalizumab or Xolair and 12 received placebo. And there was a run-in phase where you just received those injections for 8 weeks. And then at 8 weeks, we started oral immunotherapy, and we built up for 2 to 5 foods that the individual was allergic to under the cover of Omalizumab or placebo. And then, so those injections lasted only for 16 weeks. while we were building up the food, which is the black lines here. And then the food continued until week 36. And then we did food challenges to understand how much we were able to improve the threshold sensitivity for those foods. What we showed in 2018 now, so some years, is that 16 weeks of Omalizumab, the 8 weeks where we're just doing Omalizumab, and then the 8 weeks where we're doing Omalizumab and food, improves the efficacy of multi-allergen desensitization at 36 weeks to multiple foods. So 83% of those who received Omalizumab plus food were able to pass challenges to 2 grams and 4 grams of 2 or more foods, compared to only a third in the placebo arm. And that's what you're seeing here: 2 grams of food, 4 grams of food. The red is the Omalizumab arm, the blue is the placebo arm. And I just want to take a pause there and say, for those of you who know about oral immunotherapy or participated in any of our studies that are just peanut alone or a single allergen, it can take almost a year to get up to 2 grams or 4 grams of one food, to that amount. And to put it in perspective, 4 grams is 1 tablespoon of peanut butter. It's a half a glass of milk. And in 9 months in this study, 83% of folks who are allergic to more than one food were able to achieve desensitization, improve their thresholds for 2 or more foods if they were treated with the Omalizumab arm as well. We saw signals as early as 8 weeks. So I wanted, this is kind of, these studies that I'm sharing now are kind of what have built the design of future studies that I'll be talking about, like our OUtMATCH study and our combined study. At 8 weeks of just Xolair alone, we see that improves the threshold sensitivity for multiple foods. And this is where we do food introduction, and we tested as high as 1 or 2 grams. And you can see for those patients who received Omalizumab that they are able to tolerate, higher amounts compared to those people who received placebo per food at the 8-week starting point. So we were very excited about that early pilot data, and we decided to do a second study, another phase 2 study of 70 patients across 7 sites. So Stanford was one site, along with Cincinnati, CHOP, Chicago, Mount Sinai in New York, and Seattle. And it was a similar study design where we looked at 100 patients who received Xolair at first for 8 weeks alone. And then we started multi-allergen food at 8 weeks while we continued Xolair. And in this study design, what we were testing is what are the maintenance doses after kind of that initial introduction period. So all 70 participants received Xolair for 8 weeks, then the start of food plus Xolair or Omalizumab for another 8 weeks. Then food was continued up until 30 weeks, so almost 8 months, where we did food challenges at that time point. And then the randomization occurred where we studied 3 different arms. So patients were either stopped dosing with food, so they received placebo food. They decreased their dose from 1 gram down to 300 milligrams, or they continued 1 gram of each of their foods for 6 weeks. And then we did food challenges again at week 36. And what I'm showing you here is a combination graph of the folks who reduced their dose to 300 milligrams or continued on 1 gram of food compared to those who went on to avoidance. And what we see is that all 3 arms were pretty successful, and about 50% of those individuals who went on to avoidance were still able to maintain the same threshold sensitivity after 6 weeks with this combination approach for the first 30 weeks. And I think this highlights, kind of what I said in the beginning, that long-term outcomes from all of these studies are really critical to understand how durable and feasible are these approaches, these different therapeutic options for patients. And it's one thing to be in a clinical trial with a study team, and frequent visits, and then what happens afterwards, and what advice can we give to families after they finish a clinical trial? Do they have to eat food every single day to maintain that desensitization? What kind of wiggle room? Are there biomarkers that we can identify that will help us understand who is able to decrease their dose or avoid their food completely and still retain that change in their immune system that says that they're no longer allergic to that food. And I think that's what we're all hoping to find, the right treatment approach for the right individual. And it will be different for many different individuals. So the anti-Ige agents, particularly Omalizumab, which is the most studied to date, the current limitations and successes really is that we know that it shortens time to reach maintenance oral immunotherapy doses, but not the number of people who are able to reach maintenance dose. We know that this short period of Omalizumab followed by a longer period of oral immunotherapy with the foods doesn't necessarily increase AEs or adverse events or side effects, but we're still seeing GI side effects. And some of the other information that we're trying to understand is, does a combination approach with just 16 weeks of Omalizumab plus oral immunotherapy improve the outcomes of sustained unresponsiveness? The MTAC study was the first study to actually look at this, and I think it's a small study and we need larger information from that. And it was the only study actually to be done for multiple allergens, testing a period of avoidance. And there's lack of data on optimal dosage of Omalizumab or anti-IgEs and the use in oral immunotherapy. How long should we be using Omalizumab? Is 16 weeks enough? How quickly should we go if we add oral immunotherapy for the desensitization? And what's the optimal length of pre and concomitant treatment? And I think we have a question in the audience. So what is the evidence of OIT effectiveness for patients that do monotherapy without immunotherapy after they have had OIT for 3 years? Do they need to keep taking the nuts to desensitize, or can they stop at any point? This is really a great question. There's very little data on this, particularly if you've done OIT first. If I'm understanding the question, doing OIT first and then followed by biologics. And I don't think it's been, to my knowledge, looked at in that way. There have been real life studies that have come from Europe where they've used Omalizumab that's been used for other indications like asthma, and where Omalizumab is continued long-term, and they've done food challenges for food allergic individuals and noted that they have improved threshold sensitivity, meaning that when they challenge people to foods that they're allergic to after they've been on Omalizumab for their asthma, for various different foods, it's their threshold sensitivity is higher than what we would typically see from an accidental ingestion for that food. That leads me to my next slide, which is the next study, which I wanted to spend some time talking about. a phase 3 study. So the MAPX and the MTAX data plus other Omalizumab and oral immunotherapy studies that have been done across the country really led to this phase 3 study to study Omalizumab longer and really try and understand in a multi-food allergic individual, 70% of people who come to our center are allergic to more than one food. What could be the right approach for Omalizumab in these food allergic individuals? So this is the OUtMATCH study. It's conducted through the NIH, through the Consortium of Food Allergy Research, so COFAR, and it's currently enrolling across 10 sites. And it has 3 stages. We're looking to enroll 225 patients, including at our site. The first stage is trying to understand, I'm not sure if I answered that person's question, Omalizumab alone. How can Omalizumab alone change threshold sensitivity for multiple foods? And so we're looking at peanut allergic individuals who are allergic to peanut plus 2 foods, and from age 1 to 55, so we're taking all comers. This is really exciting because this is the first time that Omalizumab is being studied down to age 1, which is really important to try and understand, kind of durability of response. And this first stage is looking at treatment for 4 months and then assessing via food challenges for peanut plus the other 2 foods. And then folks go into stage 2, where everybody gets Omalizumab randomized into 2 arms from there. So either Omalizumab plus Omalizumab for a short period of time, like our MAPX and our MTAX study, and then multi-allergen oral immunotherapy. Or the second arm is Omalizumab alone for a year plus placebo oral immunotherapy. So both arms in stage 2 receive treatment of one kind. One is really trying to understand allergen oral immunotherapy with, over the course of 1 year with a short course of Omalizumab versus long-term Omalizumab for 1 year. And then there'll be food challenges at the end of stage 2. And then for the first time, we're super excited to be able to understand long-term outcomes from these approaches. And it's built into the study design. So at Stanford, we're highly invested in understanding the long-term outcomes from folks who are undergoing food allergy therapies. And we're very lucky to have philanthropic support to be able to do those types of studies. This is built into the NIH study because we thought it was such an important part to understand long-term outcomes from this study. And so stage 3 is dietary food introduction and rescue oral immunotherapy for those folks who may need it. It's very exciting. So at the end of this study, we'll have information on, a short course of Omalizumab for 16 weeks, a longer course for 52 weeks, a combination approach with Omalizumab plus multi-allergen oral immunotherapy, and then importantly, how that converts into, real foods at home after you undergo any of those treatment options, so that, you continue the success of what you were able to achieve in this study, and with the advice of your study team to be able to really try and incorporate this into your diet at home in a safe way with regular foods. I'll pause there because I think we have a few questions. How long do kids need to continue oral immunotherapy? Well, this is a really important question, and I think our long-term studies are trying to understand it. From our POISE study, we know that only about 10 to 15% of folks achieve sustained unresponsiveness, meaning that if they stop dosing after a period of desensitization, they don't have any reactivity. but we don't know how to identify those folks from the very beginning. And we're really trying to understand, is there a test that can tell us, who might fall into that category? For most folks, we recommend regular dosing and working with your allergist on what regular dosing means, and that's really kind of the art of medicine within this field at this moment, is trying to understand risk factors. And are you having side effects from your dosing? How can we find a happy medium where it's not too burdensome to do regular dosing and to keep you safe from accidental ingestions? We have another question. What are the side effects of Omalizumab? It's an injection that goes subcutaneously into the arm or thigh, typically the arm. And there is a very small, rare risk of anaphylaxis to the injection. That's really even more rare after the first 3 injections. So the injections are done in the clinic. It's now, during COVID times, had enough safety data from the asthma and the other allergy studies that the FDA approved it for home use after the first 3 injections. Most folks have some stinging or irritation at the site that doesn't last long. Thanks, Wendy, for your question. I wonder why you think the results of phase 2 was so different from phase 1 as far as the dropout rate. All the best. Would it be helpful? Yes, I'm happy to chat with you, Wendy. I'd love to hear from you. I think that dropout rates from phase 1 to phase 2, I think, it's really hard. It depends on the study and how long. I think our families are a huge part of it. Food allergy therapies are not just for the individual, they're for the families as well. And being engaged with patients and their families and their struggles, and coming up with different ways to get through that struggle. I think one of the wonderful things about our center is that we have a wonderful team of dietitians, coordinators, clinicians, therapists, and our community as a resource to be able to help people as they struggle through some of the studies, and be cheerleaders on the side, because it is not easy to go through this. Is there a risk of not being able to tolerate food allergen and having reactions ever after coming off Xolair? That is also what this study is trying to show. I think from the MAPBAC study, we saw that particular protocol, 83% were able to get through. There's a small percentage of folks who were not successful by the way we define success. And so there is a little bit of variability of response, and we're trying to understand that. And with a phase 3 study like OUtMATCH, where we're looking at 225 patients, we're really going to get so much information from this study to understand patient variability in their response to these treatment approaches. I wanted to also highlight another study that we're looking at with Omalizumab. It's a phase 2 study, or combined study, that's being done in California. So at Stanford, UCLA, and UCSD. And it's the first of its kind to combine Omalizumab followed by Dupilumab, a different biologic, targeting other allergic inflammatory cytokines in addition to IgE. Very excited to be doing that study here at Stanford too. So lots of opportunities to really study best treatment approaches for our multi-food allergic individual here at our center. And why do we do this? I think to improve the quality of life for our food allergic patients. And so I wanted to share that this is a meta-analysis that we published last year, looking at quality of life. And what it really does show is that even the food challenge, even coming into our center to do food challenges and understand your reactions to different foods, can improve quality of life of patients and treatment. But it has to be weighed by the amount of burden. I'll share one patient success story. This is Elliot Costa. She's one of our 9-year-old star patients who completed a multi-allergen protocol in August of 2021, and she's eating peanut, hazelnut, and walnut freely. And with that, I thank you guys for attending. I know we're at time. And thank you so much for coming. And I think Ada has put the links for joining our clinical trials or reaching out to us to learn more about any of our studies. We welcome you into the center. And thank you for coming to educate yourself about what's going on at our center and really spreading the word, because I think food allergy awareness, as we come off of Food Allergy Awareness Week, this last few weeks is really important. So education is part of that mission. If you like our Ask the Expert webinar series, please see our link. The videos are posted on YouTube. And there's lots of information on our website about the clinical trials that are currently active. And thanks for coming. Hope to see you in the center in person. Take care.